This recorded lecture will be going over the Exam 5 study guide for Foundations 2 in the Fundamentals textbook, covering chapters 37, 38, and 39. Starting with chapter 37. Understand the 4 stages of anesthesia. We can see the 4 stages of anesthesia on page 752, box 37.3. When providing surgical care for the older adult, what is an important safety consideration to ensure medications can be dosed appropriately? We can see that also on page 752 in the Lifespan Considerations green box. Accurate height and weight data of the older adult are important to obtain for calculation of anesthetic agents and medication dosages. Kidney function declines in the older adult, and drugs are not eliminated from the body as quickly. Reduced dosages are often needed. Is it acceptable for a patient to sign their surgical consent form with an X? Yes, that actually is acceptable in some situations. We can see that on page 753. The signature of the patient or the responsible party is witnessed by another party, often a staff member. The consent form must show the procedure to be performed and the risks involved, must include the time and date, and must be signed in ink. A witnessed X is acceptable if the patient cannot sign with a signature if allowed by institutional policy. A minor needs emergent surgery, but no family can be found to give consent. The patient cannot wait. What happens next? We're also going to find that answer on page 753. If emergency surgery is needed and the patient is not conscious or able to give consent, immediate family is contacted. Telephone permission may be given as long as there are 2 witnesses on extension lines. If a family member cannot be found, the opinion of a second surgeon regarding the need for surgery is sought, and then the surgery may take place. Consent forms need to have correct spelling and information. What should the nurse do if they notice something is misspelled on the consent form? So we can find that information on page 753 as well. So this is a legal form. It must be completed in ink with the correct spelling of the procedures to be done. The surgeon is responsible for obtaining an informed surgical consent. If part of the consent form is misspelled, the nurse should request a corrected consent be signed, and then you would shred the misspelled form. So request that a corrected consent be signed. The post-op patient in PACU is asking for a drink of water. What must the nurse do first? So we're going to find that answer on page 770. As soon as the patient is conscious and the swallowing reflex has returned, offer the patient a few ice chips or sips of water unless there is an order to maintain the NPO status. Record all intake on the intake and output record. So you would assess the patient's ability to swallow before giving them anything to eat or drink. What does preoperative skin preparation consist of? Go back a few pages for that one, onto page 757. The patient may be asked to shower with a special antibacterial cleanser on the night or morning before surgery, or both. This is to remove as many microorganisms from the skin as possible. Removing hair from the operative site may be done just before surgery, but it's not generally recommended. What are some universal safety protocols nurses need to observe according to the National Patient Safety Goals? So we can find this information on page 753 in the orange CUSIN considerations box. As part of the National Patient Safety Goals, the Joint Commission has developed a universal protocol for facilities to prevent wrong site, wrong procedure, and wrong person surgery. The protocol consists of 3 parts. It's important to mark the procedure site. The patient should be involved in this process if possible. This should be done before any preoperative medications are given so that the patient is alert and able to participate fully. Your pre-op patient tells you he does not want to take off his wedding band for surgery. As his nurse, what do? So we can find this answer on page 758. Have the patient remove jewelry, money, and credit cards and give them to a significant other to keep secure, or keep them in a valuables envelope and place it in a locked environment according to your facility policy. If a wedding band is to be worn to surgery, the nurse should tape it to the finger without restricting any circulation. Which 2 age groups are most at risk for surgical complications and why? So that is going to be, of course, our very young and very old population. And we can find that on page 750. The infant and the older adult are at higher risk for surgical complications because of either immature body systems or a decline in function of various body systems. Both of these age groups are at risk for dehydration or overhydration. How long is the anesthesia recovery period? So we can find that answer on page 760. The anesthesia recovery period usually takes 2 to 6 hours. Understand the major functions of the circulating nurse. We can see some of the major functions of the circulating nurse on page 765 in box 37.6. It's very important to observe for breaks in sterile technique and to announce them to the entire team. What system does the PACU nurse use to determine if the patient is stable enough to transfer? So we're going to go back to the page 760. Many facilities use the Aldrete scoring system to determine readiness for transfer. This scoring system will rate a patient's activity, respiration, circulation, consciousness, and skin color on a scale of 1 to 3. A total score of 9 or 10 usually indicates the patient is ready for transfer. How should the patient be positioned in the PACU after surgery? So we can find this information on page 766. Maintaining an open airway is a priority measure. The patient must be positioned on the side or with the head turned to the side to prevent any aspiration, if not contraindicated, until fully recovered, alert, and with the swallowing reflex intact. When assessing the surgical site dressing in PACU, the nurse notices sanguineous drainage on the dressing. What should the nurse do next? So we can find that information on page 767. Check the surgical site when the patient returns to the unit. The dressing should be dry. If it is stained, outline the area with pen and note the time so that further bleeding can be assessed later. If the bleeding has saturated the dressing, reinforce it with more dressing supplies. The dressing should not be changed without an order to do so. What are appropriate interventions after surgery to promote respiratory function? Does it matter if the patient is post-op from brain surgery? So we can find that on page 767 and 768. Assess the patient rate and depth of breathing and encourage the patient to deep breathe and cough every 2 hours. Coughing can be contraindicated for patients who have had hernia repair or eye, ear, or brain surgery. Be sure to check the surgeon's orders. The use of an incentive spirometer is also especially helpful to prevent any atelectasis and hypoventilation. The older adult patient might need extra coaching to master that technique. What is the purpose of sequential pneumatic compression devices? So we can also find that answer on page 768. If the patient is at risk of venous thrombosis, blood clot, the surgeon will order a sequential pneumatic compression device to be applied to the legs and/or an anticoagulant. These devices will alternately compress and release, squeezing the vessels and propelling the blood along them. How much urine should the post-op patient produce 2 hours after surgery? What if they're not producing that specified amount of urine? So we can also find that answer on page 768. The urine output needs to be monitored after surgery. If the flow is less than 60 mL over a 2-hour period, you need to notify the surgeon. Your post-op patient is hungry and asks for something to eat. What must the nurse do first? Well, again, just as we had said before, the first thing you want to do is check your orders for any type of diet. You want to, of course, assess your swallowing reflex. And we want to also keep in mind that eating is not allowed until bowel sounds have fully returned after surgery and general anesthesia. This is due to the risk of development of paralytic ileus. So the nurse needs to also listen for any bowel sounds and document them once per shift. So you would need to do that before you gave your patient anything to eat. Your post-op patient complains of gas pains. What are some interventions the nurse could try to alleviate that pain? We can find that information on page 771. Abdominal distension and considerable flatulence may occur after general anesthesia because the gastrointestinal tract action ceases. This can cause discomfort. Ambulating is helpful in moving and evacuating this gas, taking only small amounts of liquid or food at a time, drinking liquids that are neither very hot nor very cold, and refraining from drinking with a straw will help keep gas to a minimum. If permitted, the patient can try resting in a slight Trendelenburg position with the legs and rectum higher than the stomach. This can also assist in the evacuation of flatus. Chewing gum, if permitted, can also aid the return of proper GI function. Orders for ambulation can begin 8 hours postoperatively. Raise the head of the bed first and let the body adjust to the position change. Then sit your patient on the side of the bed, allowing the legs to dangle over the side with the feet on the floor. After a few minutes, slowly help the patient to stand. So that was the answer for the next one. When getting the post-op patient out of bed for the first time out of surgery, what's an important safety step? So it's that dangle. So you will recall that from previous chapters that we've read, and you can also read about it on page 771. We want to raise the head of the bed first, let the body adjust to that position change, have the patient sit on the side of the bed, let the legs dangle, and then after a few minutes, help that patient to stand. How long is the recovery period after same-day surgery? We can find that answer on page 764. Recovery time in the same-day surgery unit will take about 1 to 4 hours. What essential elements need to be included in a surgical consent form? So we can find that information back on page 753. So, and we kind of went over that earlier, what needs to be on there. I had read it, but it needs to show the risks involved, the procedure to be performed, the time and date, and it needs to be signed in ink. Of course, needs to have the patient's full name, needs to have their signature, fully correct spelling, and it is a legal form that needs no abbreviations. How should the nurse prepare the room for the patient who is expected to return from a surgical procedure later? So we'll find that information on page 758. While patients are in surgery, prepare the patient unit for their return. Make the bed with fresh linens, including a draw sheet placed at shoulder height. Place an underpad at the hip area. fan fold the top covers to the far side of the bed or to the bottom of the bed. Have the bed in a raised position at the height of the gurney that will return the patient, and arrange the furniture so that that gurney can be pulled up alongside the bed. Gather an emesis basin, tissues, a workstation on wheels, frequent vital signs sheet or post-operative record, an intake and output sheet, a small towel and a washcloth, a pencil, and place these items on a bedside table or the console. Place an IV pole at the head of the bed. Connect oxygen and suction equipment if their need is anticipated. A thermometer, sphygmomanometer, and stethoscope, as well as a pulse oximeter, should be nearby on the patient's return to the unit. If a PCA pump, sequential pneumatic compression device, or a passive range of motion machine will be needed, see that they are obtained and ready for use. Describe dehiscence. We can find that on page 772. Dehiscence is the separation of layers of the surgical wound. Evisceration is the extrusion of the viscera through a surgical incision. This can occur when a patient is coughing, particularly if the abdominal incision is not properly splinted. Who is ultimately responsible for having the surgical consent form signed? So again, that's going to be back on that page. It's going to be in the bolded text on page 753. The surgeon is responsible for obtaining an informed surgical consent. What is the highest priority to assess when a patient arrives to the PACU after surgery? Go back to your ABCs and remember that A is airway, which is our priority assessment. You can also see that on page 766 in the bolded text. Maintaining an open airway is a priority measure. And that's why we position the patient the way that we do. Moving on to chapter 38, providing wound care and treating pressure injuries. What is the first stage of wound healing? We can see this on page 777. No matter what the cause of the wound, healing occurs in 3 distinct phases: the inflammatory phase, the proliferation or reconstruction phase, and the maturation or remodeling phase. Inflammation is a localized protective response brought on by injury or destruction of tissues. The inflammatory phase will begin immediately after injury and last approximately 3 to 4 days. What types of wounds typically heal by primary intention? Secondary intention? We can find this on page 778. A wound with little tissue loss, such as a surgical incision, will heal by primary intention. A wound with tissue loss, such as a pressure injury or severe laceration, a torn, ragged, or mangled wound, will typically heal by secondary intention. The edges of that wound will not approximate, and then the wound would be left opened to fill with scar tissue. Is swelling normal during initial wound healing? Yes, it is, and we can see that on page 777. Small blood vessels will dilate and become more permeable, causing serous fluid to leak into the traumatized area. The collection of plasma and electrolytes leaking into the interstitial spaces will cause edema. The wound will become red, swollen, and tender. How does smoking affect wound healing? Smoking will delay wound healing, and we can see that on page 780. Smoking reduces functional hemoglobin of the blood, which limits oxygen carrying capacity. The person who does not smoke and who exercises regularly will typically heal more quickly. What are signs and symptoms of internal hemorrhage? We can see this information on page 781. Internal hemorrhage is evidenced by swelling or distension in the area of the wound, and perhaps sanguineous drainage from a surgical drain. If internal hemorrhage is extensive, hypovolemic shock can occur with a fall in blood pressure, rapid and thready pulse, increased respiratory rate, restlessness, diaphoresis, and cold, clammy skin. Intervene promptly to prevent a potentially life-threatening situation. What is a sign of possible impending dehiscence? So we can find that information on page 782. Dehiscence is the spontaneous opening of an incision. Dehiscence of an abdominal wound often involves separation of the layers beneath the skin as well. A sign of impending dehiscence may be an increase in the flow of serosanguinous drainage into the wound dressing. When dehiscence occurs, the patient might state that something has given way. If dehiscence or evisceration occurs, quickly place the patient supine and place large sterile dressings or towels soaked with normal saline over the incision and viscera. Notify the surgeon immediately and prepare that patient to return to surgery. Your patient is exhibiting possible signs of dehiscence. What should the nurse do next? So that's what you do. Notify the surgeon and prepare them to return to surgery. Know the steps for emptying a closed wound drainage unit while prioritizing minimizing any risk of infection. So we can see that on page 784 in steps 38.1, maintaining a closed wound drainage unit. And you'd want to pay attention to numbers 2, 3, 4, 5, and 6. Hold the device with the spout pointing away from you and release the vacuum by gently removing the plug from the pouring spout. This will allow you to avoid contaminating yourself if the fluid would squirt out of the spout. Don't touch the drainage spout or plug. Empty the contents into a measuring container, noting the amount and appearance of the drainage. Clean the pouring spout and plug using a separate alcohol sponge for each. This will prepare it for reinitiation of vacuum and suction. Then reactivate the unit by fully compressing it. What is a benefit of a non-adherent dressing, also known as TEFLA? So we can find this information on page 784 as well. TEFLA and other non-adherent dressings have a shiny, non-adherent surface on one side that is applied to the wound. Exudate will seep through the surface and collect in the absorbent material on the other side. This dressing will cause less wound trauma when it's removed. What are the benefits of Montgomery straps? So we can see that information on page 785. Montgomery straps allow changing of the dressing without removing and reapplying tape. This can cause repeated skin irritation. Dressings are secured to a wound using tape, stretch roller gauze such as Conform, Curlex, or Cling gauze, mesh netting, an elastic bandage, or Montgomery straps. These are tie tapes. It's important to select the correct product for the right purpose. What types of wounds will benefit from transparent film dressings? We can also see that on page 785. Transparent film dressings, such as Opsite or Tegaderm, will allow you to assess the wound without removing the dressing. The transparent dressing does not require the use of tape, and it's less bulky than a gauze dressing. These dressings are often used to cover intravenous catheter sites, and sometimes used to protect a stage 1 or stage 2 pressure injury. They do not absorb drainage, so they may be used as a secondary dressing to secure a primary wound dressing that will absorb wound exudate. Define hematoma. So we can see the definition of hematoma on page 776 in table 38.1, wound types and characteristics. A hematoma is a tissue injury that damages a blood vessel, or a hematoma results from a tissue injury that damages a blood vessel. It appears as a pooling of the blood under unbroken skin. When performing a sterile dressing change, how should the nurse use the swabs to clean the wound prior to applying a new dressing? So we're going to see that information on page 791 in Skill 38.1, Sterile Dressing Change. Take a look at number 4. Perform hand hygiene. Don clean gloves. Loosen the binder or tape, remove the old dressing, and pull off the tape towards the wound while stabilizing the skin with the other hand. So that goes over number 4, we're going to come back to later on in the study guide review. For this question specifically, you're going to look on page 791 within that skill, but look at 7C. Use a circular motion from the wound outward in an ever-widening circle. The nurse is performing a dressing change, and while removing the tape on the old dressing, it's sticking to the patient and causing pain. What can the nurse do to make this procedure more comfortable for the patient? So it talks about it as well on this page here, 791, and it would be step 4. Perform hand hygiene, don clean gloves, and loosen the binder or tape. Remove the old dressing and pull off the tape towards the wound while also stabilizing the skin with the other hand. If that tape won't loosen, rub over it with an alcohol swab for several seconds or use an adhesive remover. Wet the dressing with normal saline solution if it sticks to the suture line, and then wait a few minutes before removing it. Assess any drainage on the dressings and place them in a plastic discarded bag. Pulling tape towards the wound will prevent disruption of the wound. An alcohol or adhesive remover will help loosen stubborn adhesive. We can also see a little bit more about this technique on page 786. To remove tape, gently loosen the tape ends and gently pull each parallel to the skin surface towards the wound while applying light traction to the skin away from the wound as the tape is loosened. If the tape will not loosen, use adhesive remover. Alcohol pads also work great. What are hydrocolloid dressings for? We can see this on page 789. Hydrocolloid dressings are applied only to uninfected wounds. They keep the wound moist and block entry of microorganisms. A variety of hydrocolloid dressings are available for use. How should the nurse pull the tape off the previous dressing? So again, we went over that, and you can find that information to read over again on page 786 and 791. How should the patient be positioned for eye irrigation? So we can find this information on page 799 within steps 38.4, irrigating the eye or adult ear. And take a look at number 1. For irrigation with a syringe, place the patient in a supine position with the head angled in the direction of the affected eye. Position the examination light to illuminate the affected eye. Place an underpad and towel on the bed to protect the linens and clothes. Place an irrigation basin close to the face to catch any irrigation solution. When removing staples, the nurse grasps the staple in the staple remover and pulls blank. Take a look at page 798 for this answer. You're going to be looking at steps 38.3, removing sutures or staples, and take a look at staples number 9. When both ends of the staple are visible, lift it up and away from the skin. Drop the staple into the discard bag. So pull outward. This will remove the staple and prevent the transfer of any microorganisms and injury by a sharp object. You want to pull out and away from the skin. How does vacuum-assisted closure work? I'm going to go back to page 786. The therapy, also known as vacuum-assisted closure, or VAC, involves applying a suction device to a special wound dressing to institute negative pressure at the wound site. This will draw the edges together. Why are immunocompromised patients, like a patient with HIV, more at risk for delayed wound healing? Well, it's because their immune system is compromised, which builds all of our wound healing. And we can see more about this on page 780. Patients who are immunocompromised with poorly functioning immune systems will have delayed wound healing due to their fibroblast function, collagen synthesis, and phagocytosis being affected. Which medications affect or delay wound healing? We can see this on page 780 as well. The use of steroids, immunosuppressants, and other anti-inflammatory drugs, anticoagulants such as heparin, and anti-neoplastic agents will interfere with various aspects of the healing process. How does age affect wound healing? We can see this on page 778. Metabolism and regeneration in the chronically ill and older patient are slower. Peripheral vascular disease will impair blood flow, and this can impede healing. Atherosclerosis and atrophy will reduce skin capillaries and impair blood flow to the wound. A decline in immune function will reduce the formation of antibodies and monocytes necessary for wound healing. How does chemical debridement work? We can see this on page 783. Chemical debridement using a Dakin solution or sterile maggots is occasionally used on a wound with necrotic tissue that is not responding to other treatments. Define a keloid. We can see this on page 778. If collagen overgrowth occurs, which is frequent in dark pigmented skin, a keloid, a permanent raised and large scar, will occur. Why should the nurse refrain from applying heat to the site immediately after surgery? So we can see this information on page 802. It's going to be in the red safety alert box. Heat is not usually applied immediately after injury or surgery because it increases bleeding and swelling. Moving on to chapter 39, promoting musculoskeletal function. What is hypostatic pneumonia and how can it be prevented? We can see that on page 806. Without adequate physical activity, secretions can collect in the lower airways, leading to congestion and ultimately respiratory illness, particularly hypostatic pneumonia. This is pneumonia caused by a stasis of secretions due to inactivity, or hospital-acquired pneumonia. One of the major concerns when a patient's movement is restricted is the development of respiratory complications. How does movement affect circulation? We can also see that on page 806. Circulation is affected by immobilization. Normal movement assists in venous return by compression of the muscles against the venous walls when the muscles are in motion. Healthy, firm muscles will provide general support for the venous walls. The dangers of immobilization include pressure injuries, loss of bone mass, pneumonia, and permanent loss of function. How should traction be set up correctly? So we can see that information on page 808 and 809. The head of the bed should be no higher than 20 degrees, unless ordered, to keep the patient from sliding down in bed and to keep the weights hanging free. A slight Trendelenburg position may be ordered to keep the patient from slipping down in the bed. The weights should swing freely without touching the bed or floor. What is the purpose of traction? We can see that on page 808. Traction is the application of a pulling force, and it's used to maintain parts of the body in extension and alignment. It's used to realign bone ends following fracture and to relieve pain and nerve impairment caused by compression or muscle spasm. There are 3 types of traction: manual, skin, and skeletal. Is drainage from skeletal traction normal? We can see this information on page 810. Clear fluid drainage is expected initially. How long will it take for fiberglass cast to set and be durable? We can find this information on page 811. So you can find this answer on page 810. Cast made of synthetic material will dry rather quickly, in about 7 to 20 minutes, and can be hardened enough to be durable within 30 minutes. How should the nurse handle the cast during the drying period? So we can see this on page 811 in the clinical cues box. When handling the cast during the drying period, use the palm and flat parts of the fingers rather than the fingertips. Dents in the cast can lead to circulatory impairment and pressure injuries. And changes in alignment can alter the position of the healing parts or impede circulation. You're about to remove your patient's cast, and they ask you what it will look like. How do you respond? We can see this on page 812 in the clinical cues box. Prior to cast removal, inform the patient that the skin underneath will be dry and dirty in appearance, with an unpleasant odor. Wash with warm, soapy water, rinsing and applying cream or lotion to remove the dead skin cells and help the skin return to normal. You can apply vitamin E or other recommended ointment over the healed incisions to improve their appearance. Air fluidized beds are contraindicated for which patients? We can see that on page 812 as well. Air fluidized therapy is not recommended for patients with unstable spines or ambulatory patients. What is an advantage of low air loss beds? We can also see that on page 812. Shear and friction are reduced or eliminated because of the cushions will give with the patient during any movement or rest. When using a continuous passive motion machine, who sets the limit of flexion, extension, and speed control? So we can find this information on page 815 in steps 39.1, use of a continuous passive motion machine. Connect the control box to the CPM machine and set the limits of flexion, extension, and speed control to prepare the machine for functioning. So you would be the one to set those settings. What are the 5 Ps? Understand what would be considered normal and abnormal during a neurovascular assessment. So we can find this information on page 815 in box 39.3, neurovascular assessment. Now the 5 Ps are extremely important to know and memorize for your assessment purposes. We always use these to assess our neurovascular system, and any 5 of these, when found in a patient, is something that's going to warrant notification to the doctor and some type of intervention to reverse or stop that process. Our 5 Ps are pain, pallor, paralysis, paresthesia, and pulselessness. Be very familiar with that table. What is considered normal when assessing capillary refill? Capillary refill of the affected extremity should be less or equal to 3 seconds, or within 5 seconds or less in the older adult patient. That's 815, also in that same table. How can you reduce the incidence of edema in a casted extremity? So you can find this on page 811. A casted extremity should be elevated on pillows. What are guidelines to follow when applying an elastic bandage or a roller bandage? We can find this information on page 821, and you can see it in box 39.4, guidelines for applying an elastic or roller bandage. We want to overlap turns of the bandage equally. What are guidelines to follow? Oh, I just did that one. Describe a circular turn. We're also going to be on page 821 for that. Circular turns are used to anchor the bandage and to terminate the wrap. When applying a triangular bandage sling, how should the nurse position the hand and the elbow? So I know I've talked about this in class, but you can also see this on page 823 within steps 39.3, applying a triangular bandage sling. Take a look at number 3. Bring the other end of the injured arm and the shoulder. Bring the other end over the injured arm and the shoulder while the patient keeps their elbow bent at a right angle across the lower chest. The hand should be 4 inches higher than the elbow. Elevating the hands will prevent the fingers from swelling. How should the mechanical lift be positioned when preparing to transfer a patient? We can see this on page 824 within skill 39.3, transferring with a mechanical lift. And take a look at number 7. Position the lift. Widen the stance of the base of the lift and lock it into place. Position the base under the bed so that it hooks for the sling. Position the base under the bed so that hooks for the sling are over the patient and in line with the hook openings on the sling. When fitting a person with a new walker, how can the nurse be sure that the walker is at the appropriate height for that patient? We can see this on page 825. Walkers are adjustable in height. The height is correct if the person's elbow is bent at a 15 to 30 degree angle while standing upright and grasping the hand grips. How would the nurse instruct the patient with crutches to walk up the stairs? We're going to see this on page 827 in the blue patient education box, special maneuvers on crutches. Take a look at walking upstairs, numbers 1 through 4. Stand at the foot of the stairs with the weight on the good leg and the crutch. Put the weight on the crutch handles. Lift your good leg up onto the first step of the stairs. Put your weight on your good leg and lift your other leg and the crutches up to that step. Now repeat that for each stair step. What is an important safety check that must be assessed prior to getting a patient into or out of a wheelchair? We can see this on page 827. It's in the bolded text. When moving someone into or out of a wheelchair, always set the brakes. What are some pressure relief devices that could prevent skin breakdown in the immobile patient? We can see this on page 813. There are a variety of accessories that aid in the reduction of skin trauma from pressure for patients in standard hospital beds. These include foam and gel pads, sheepskin pads, and heel and elbow protectors. Pulsating air pads and water mattresses can lie on top of the regular mattress, providing additional pressure relief. What are some education points the nurse would need to go over with the family of a patient being discharged in a hip spica cast? So for this, we're going to look on page 811, and we're going to look at the bolded text. Do not use the spreader bar as a handle for lifting and turning the patient. It may be dislodged, ruining the cast and causing pain and possible injury to the patient. Instead, grasp the cast over the leg to assist in turning. Frequent turning is necessary, including the prone positioning, to ensure complete and uniform drying. This will also help protect the cast from soiling. What are some dangers or consequences of immobilization? So we're going to go back to the beginning of the chapter for that. Some dangers of immobilization include pressure injuries, loss of bone mass, pneumonia, and permanent loss of function. And we can see this on page 806. We want to encourage active movement of unaffected extremities throughout the day to assist our patients in maintaining their muscle tone. And we want to be sure to turn our patients every 2 hours to keep their skin clean and dry and provide smooth, clean linens to relieve and use pressure relief devices to help relieve any pressure injuries. And what is the maximum weight that can be used in skin traction? That's going to be on page 809. The amount of weight that can be applied is limited to a maximum of 10 to 15 pounds. Also on page 810, please see box 39.2, some guidelines for pin care. And just remember that it's important to use sterile swabs and cleanse closest to the pin in a circular motion. And always be sure to secure the ends of the wire with cork.